The BC chapter of the Canadian Association of Critical Care Nurses welcomes you to our spring roundtable that was held in April of 2024. These were three of the presentations that were shared. The second presentation was led by Fiona Howarth, and she discussed a nurse-led quality improvement project for combating risk factors for ICU delirium.
My name is Fiona Howarth. I'm now a clinical nurse specialist with Fraser Health Critical Care. When I did this work, though, I was the clinical nurse educator at Abbotsford ICU. So I want to first and foremost respectfully acknowledge that the place where this work took place, as well as where I'm calling in from today, is located on the traditional, ancestral, and unceded territory of the Stolo, Sumas, and Matsqui First Nations people, and I invite you to consider the traditional territories from which you work from as well. So first and foremost, I have no conflicts of interest. I've not received compensation from any company because I will be speaking about a monitor we used in ICU, and I'm in no way affiliated with that company. But I did work with Health Quality BC's Quality Academy on this project, so they helped support me in the development of this QI work. So first, I'd like to situate the work, which I'll be discussing by introducing the site where it took place. So it took place in Abbotsford Regional Hospital, and for those of you outside the Lower Mainland, ARH is a 300-bed tertiary trauma hospital. We're 70 kilometers east of Vancouver, and our ICU is a 20-bed medical surgical mixed unit. So we developed a nurse-led quality improvement group in our ICU. We started this work in third wave COVID, which was the best time to start a project, and then it carried through for the subsequent year. So we first and foremost surveyed our nursing and allied health staff about what were the problems they saw in the ICU, and then did they have any suggestions for improvement? And one of the things that many of the nurses brought forward is they didn't like how prevalent delirium was in the ICU, and they didn't like how disempowered they felt about dealing with delirium. So we all know that delirium is a pervasive condition within the ICU, affecting approximately 80% of mechanically vented patients. I know where I worked, it had long been accepted as part of our patient's trajectory and a part of critical illness. And we found that when we surveyed the literature, most patients in ICU have a median duration of delirium of 2 to 3 days. So we were looking at where did our ICU fall within this, and then what could we do differently than what we were currently doing in our ICU. This was particularly important to us because we knew that delirium can lead to symptoms similar to PTSD, and 1/4 of all patients who leave ICU suffer from PTSD once they leave. So this is the same comparable rate to combat veterans and rape victims, just to contextualize how prevalent that is. And we did find in the literature that patients in ICU who did get delirium were less likely to survive and more likely to suffer long-term cognitive damage if they did survive leaving the hospital. So we know there's a number of consequences to delirium in ICU. For our hyperactive delirium, sometimes we reintubate them to manage that. There's an increase in ventilator days. There's a longer length of stay both in ICU and in hospital for patients who are delirious. There's an increased rate of mortality. They have worse long-term outcomes. Patients have decreased functional capacity when they go home, if they are even able to return home. And delirium is a risk factor, the biggest risk factor for post-intensive care syndrome, and is also a risk factor for post-intensive care syndrome family. So when we surveyed the literature about what the patient's actual experiences of ICU delirium were, we looked at studies that qualitative studies that looked at patients describing their experiences, and these were some of the themes that came out. Some of the direct quotes from the studies were, I felt like I was living in a bubble. I couldn't move my arms and legs, and people are around me, but no one answering me. I'd be calling out to people and no one would look up. My voice did not obey me. I had fantasies and was horrified the nurses were dangerous, and that it was the worst nightmare, seeing things like the devil sitting by their bedside. So we presented the study findings, like when we surveyed the literature, to frontline staff and framed our project around really what was the patient's experience of delirium and then what could we do differently. We also discussed with frontline staff about post-intensive care syndrome, which is 3 components where people who survive ICU have cognitive impairments, mental health problems, and physical impairments when they go home. And its post-intensive care syndrome is categorized by a new or worsening function of one or more of these following areas. And then family members have post-intensive care syndrome family where they have mental health problems after their loved one leaves the ICU. So the aim of our project was to decrease the percentage of delirium days in our ventilated and sedated patients by 50% in April 2023. And we started this work in April, this particular project in April 2022. So we surveyed the literature and looked for a number of change ideas about what we were doing and what we could do differently. So I just wanted to touch on a few of these. Some we had more success with than others, and I'll just speak to each one. So we did add eye shades and earplugs to each of our bedside nursing carts, and educate the staff about the importance of trying to promote sleep at night and the difference between sedation and sleep. And then we added a space in our documentation for nighttime documentation to tick off if they give eye shades and earplugs, and we did encourage it for use in all sedated patients. We installed visible clocks in every room with hands so that patients could see them. Our clocks in our rooms are historically behind the patients, so they couldn't see them. We introduced ICU family diaries, which I'll show in just a sec. And finally, we introduced neurological monitors to guide depth of sedation. So we made these family diaries. So this is the front of the diary, and then we put it on the front of a notebook. And so one aspect of our delirium prevention was the introduction of these diaries, and we give this diary to all family, one to every family when the patient's admitted to ICU. The family is encouraged to write entries about what is happening to the patient when they're in ICU, questions for the medical team, and what is said in round. So it gives them a place to store kind of all the information. What we found when we looked at the literature where diaries are important, as patients who have been sedated and ventilated often need to reflect retrospectively on their experiences, and they need those pieces to fill the gaps in their memory about what went on when they were sedated, and this helps them do that. So diaries enable patients to make sense of their ICU experiences, which they previously failed to understand. And so we put on the front an explanation of what the diary is. We gave the family permission to take part in patient care to help reduce PICS family. That was one of the solutions to that. And then we also encouraged family care rituals about what they could do to make the ICU environment more home-like. One of our family members did say this to us because I did survey the families about the diaries afterwards. So she said, the family diary gave me a place to organize my thoughts. Everything was so overwhelming in a whirlwind the first few days my husband was in the ICU. And the diary helped me look back and reflect on what happened and work through my feelings. The diary made me feel like I had some control when all my control was taken away. And what was really interesting is we had a couple of post-arrest patients that survived and went down to the cardiac unit afterwards. And two of those patients, some of our nurses saw them walking around the hallways in the cardiac unit reading their diaries. So I didn't ask them what they thought about it, but it was really impactful for the nursing staff. So that brings me to what was novel in our approach to delirium management, because these other interventions, they've been studied, they have varying levels of efficacy. So we wanted to see what could we really do as nurses to make a difference. So we wanted to really look at what we did with sedation in our ICU. As I think most of the audience is ICU based, I'm not going to go into what RAS is, but we do know we titrate sedation based off RAS. That is the gold standard for us to follow. RAS gives nurses quite a bit of leeway to make subjective decision about how much sedation to administer, particularly our RAS of -5 patients, because we all know there's a RAS of -5, and then there's a very, very deep RAS of -5. And so we were trying to target how do we manage our sedation in those heavily sedated patients. Again, when we went back to literature and closely monitored clinical trials, patients were found to only be at a target level of sedation about 69% of the time, which is higher than what I thought it would be. And in ICU, we do know that oversedation does happen at times, which has an increased risk of delirium, days on a ventilator, and increased days in ICU. We know that RAS scales are subjective because it looks at patient movement. And what we also knew in our ICU, which I don't think is only in our ICU, is that oversedation was particularly common at night. And so our change idea was implementing a processed EEG monitor, which is a depth of sedation monitor that was validated for use in ICU, but was traditionally used in the OR, to help manage our sedation in our patients in conjunction with RAS. So what this is, it's a 4-channel processed neurological monitor used to titrate sedation. It monitors brain activity, it analyzes the EEG signals, and outputs quantitative values. It was originally used in the OR, but what we did, so the company didn't sell it to us as a depth of sedation monitor. That's not why we originally purchased it. They were talking to the ICUs about it for your seizure management, for when you don't have a formal EEG available, for your kind of RASMIZE 5 patients that might still be seizing. And for the ICU I worked in, we didn't have EEG capabilities on nights and weekends, so we thought this might fill the gap for us. So we were using it for that. But when we were in third wave COVID and we were proning and paralyzing every patient, we had a lot of novice staff asking, how do I know if my patient's sedated enough to add a paralytic in, which is kind of like an age-old ICU question. So we started putting these monitors on our patients to see if they were sedated enough prior to adding the paralytic in. And we found that our patients were profoundly over-sedated. And part of this might have been because we were sedating to add a paralytic in, but that made us curious, what were we doing to all of our patients, not just those ones that we were paralyzing? So what we did about the structure of our QI project, it's nurse initiated, put these monitors on, our physician colleagues were on board with this. We started to put them on all patients who were sedated and mechanically ventilated, who were RAS of -3 to -5. There was some nursing discretion about who they included in this QI project. What we found was nurses picked patients who they perceived as being sicker to put the monitor on, who they perceived as being more likely to be on a ventilator longer, and who were on higher doses of sedation and analgesic. So we did, with the QI project, we captured more acute patients than patients that may have only been vented for like 24, 48 hours. So just kind of keep that in mind. Again, this was in COVID, I wasn't going to be a stickler and say you had to put it on every patient. I let the nurses use their discretion with that. So what the monitor helps us avoid. So I want to provide you just one clinical, for example, from our ICU, showing sedation management. So this first bit, this patient was on some Fent, some Prop, and some Midaz. The Midaz got weaned off, but was on some Fent and Prop for sedation. This is a RAS -5 patient. This patient was on a pEEG monitor to get that sedation titrated. So you see a pretty stable dose of sedation. Part of this QI work is the nurses could remove the monitor whenever they wanted, like when they were supposed to remove it when the patient's waking up, but sometimes the nurses would remove it because they didn't want to chart the numbers, because they do have to chart hourly numbers. So at 2100, the pEEG monitor was discontinued. So again, this was at night. And this was what happened to the dosing of drugs that were given to this patient. There was no change this was a respiratory failure patient. There was no change in blood gas. There was no change in vitals. There was no change in like over breathing the vent or anything else. This was purely a change based off of titrating on RAS instead. So although the use of IV analgesic and sedation therapy in the ICU is commonplace, achieving optimal sedation level is often hindered by adverse effects such as ventilator asynchrony, hemodynamic instability, and patient agitation. We know that deep sedation and exposure to sedation is associated with acquiring delirium in our patients. And what we found in literature as well was that there was a thought that fluctuations in sedation levels may also contribute to the development of delirium in ICU patients. And the risk of developing delirium might be reduced by maintaining a stable sedation level. And so the monitor helps give us that continuous measurement so that there's not those fluctuation in depth of sedation. One of the other things this monitor helps us with is the state of burst suppression in our patient, or suppression episodes in our patient. There is a colorful spectrogram at the bottom of the monitor where you can see when your patient becomes sedated to a state of suppression, whereas we don't know any of that information with observational scales alone, of course. So we can see this in our patients and we can avoid it. EEG patterns of suppression, which is a completely sedated brain, have been associated with worse patient outcomes, including higher mortality. So it's important to avoid that level of sedation in most patients. In 2019, there was an observational study, about 125 patients in an observational study who were mechanically ventilated, and they found that burst suppression occurred in 39% of those cases and was found to be an independent predictor of increased risk of death at 6 months. And then in another study, again in 2019, prior to COVID, it was found that the amount of time patients spend in burst suppression during a coma, as measured by one of these monitors, was an independent predictor of prevalence and time of resolution to delirium. So there wasn't a lot of literature based on using these monitors in ICU, but there was like a little bit. And then in 2022, the Neurocritical Care Society released some practice recommendations about pEEG monitor use in ICU. What they did say is quite a long practice recommendation, but what was really relevant to our QI work was that the monitor was adequate to monitor depths of sedation in ICU. They did state that burst suppression should be avoided at all costs, except in the case of TBI. All patients receiving sedation in ICU should be monitored by these monitors as soon as possible. And they said for any patient who clinical evaluation is not possible, so your RAS of -5. And they did say anyone who, even in deep sedation, -3 to -5 RAS would benefit from the monitoring. And their recommendation was the monitor should be used continuously, starting as soon as possible on ICU admission, which was really our goal. This was our goal before these practice recommendations were put out, but it was very nice to actually have some practice recommendations around the work we were doing. That's the background. Our results. So in our QI group, we enrolled 144 patients in the year, and we monitored them with both the monitor as well as RAS to maintain gold standard. We compared this to retrospective patients in our ICU prior to implementation of the monitor, and we looked at 223 patients in that group monitored with RAS alone. This is the demographics of the two groups. In our QI group, we did find that of those 144 patients, 38% of those guys died, but 62% lived. And of those, 90% of those guys went home. 8% went to rehab, and only 2 of those patients went to residential care. These are the admission diagnosis between our QI group and our retrospective group, and they were relatively similar. Okay, so kind of get into the crux of why we think, I'm going to talk about the outcomes of our patients in a sec, but this is, I think, the crux of why our outcomes really changed. So I'm going to show you 3 graphs of our fentanyl infusions, our propofol infusions, and then we had a couple of people on midaz infusions as well. We tried, obviously, not use midaz, but this was what happened to our drug dosing between our RAS monitored patients, our retrospective group, and our neural monitored patients. So because we know drug dosing changes, like drug dosing between patients can be super variable. Like one person can be on 10 of prop, another person can be 90 of prop. So what we did to try and compare these people was we look at the rate or the dose the infusion was started at, and then the percent change over time. Like, do they increase the dose by 10%? Do they decrease it by 10%? To try and standardize how we looked at this stuff. So fentanyl, our blue group is our neural monitor groups versus our green group, which is our RAS monitor group. So when they started on their infusions, the RAS monitor group saw fentanyl increase over time at the 24-hour mark, and then kind of come down a little bit at the 48-hour mark, but still not to that initial dose, where the pEEG monitored group stayed pretty consistent at the 12-hour mark and then fell off as time went on. So they had a decreased dose from their initiation dose. And we found that the differences between these two groups were statistically significant at the 12 and 24-hour mark. So similar results in the propofol. So again, the initiation dose, the pEEG monitored group saw a decrease in dosing from the initiation dose, where the RAS monitor group saw an increase of between starting and between initiation and further dosing. And they didn't even return to baseline in that 48 hours where the neuromonitor group had gone down. And all three of these time points, the 12-hour, 24-hour, and 48-hour time points, were statistically significant. After the 48 hours, we stopped looking at these numbers because we were usually weaning at that time and actively waking our patients. We weren't keeping them as sedated anymore. And important to note is, despite these decreasing in drug dosing in our neuromonitor group, we didn't have any adverse outcomes. We looked at worsening blood gases, self-extubation, worsening respiratory status, hemodynamic instability. We didn't see any adverse outcomes in any of these patients. And finally, this was a really, really small sample size of our midazolam group. And again, we saw exactly the same thing. Patients titrated by RAS alone saw an increase in dosing from initiation, where people titrated on the monitor saw a decrease. So we found that we eliminated some of our historic ICU problems. One interesting thing which we hadn't anticipated was the fact that there wasn't any increase in sedation at overnight anymore, which is what we had seen in our retrospective group. Is at night, sedation would go up, in the morning, sedation would go down. We no longer saw that in the neuromonitor group. So that eliminated a long-standing problem. And we did find, out of all of our patients who survived and left the ICU and went to the ward, only 3 of all of these patients were transferred to the ward with active delirium. This is a very busy graph. Anyways, what this is saying is looking at our days of delirium in yellow and our ventilator days in gray. So these patients are not patients that were only on a ventilator for like 24, 48 hours. You can see there was an outlier that was on a ventilator for 40 days. But the average days of ventilation in all of our patients was 7 days, so about a week. So one of our outcomes, well, our primary outcome we were looking at was days of delirium. So in our historic group, our retrospective group, our mean days of delirium was 2.8 days, which was well within the national average. And we found that our mean days in our pEEG monitor group went down to 1 day, which was a 64% reduction compared to the RAS monitor patients. We saw our days of ventilator decrease as well. Median days of mechanical ventilation in the retrospective group was 6 days, and in our pEEG group, it was 4 days. So it was a reduction of 30% in our ventilation, which both the reduction in delirium and the ventilator reduction is statistically significant. And although we are here specifically, and what our project was focusing on was patient outcomes and patient experience, there is some cost savings associated with this. So there are, in literature, estimated costs about days of delirium in ICU and days on a mechanical ventilator in ICU. So we did look at that literature and estimated our cost savings, saying if every patient through our ICU in that year was put on a monitor and had similar outcomes to this study group, what would the potential cost savings be for 1 year? So if we reduced our delirium by 64% in all of our patients, all our vented patients in ICU, in Abbotsford ICU, we would have saved just over $600,000 in the 12 months. If we saw the same outcome of a 30% reduction in days they spent on the ventilator, that was a projected cost savings of $1.8 million in 12 months if we had every patient in ICU on it. So about $2.5 million in our ICU alone, potentially. And then finally, this is the team I want to honor with this presentation. So while we had some amazing outcomes, no one does anything alone. I came up with an idea, but it was the frontline staff who really did this work and made it successful and were key in anything in these projects. So I just really want to honor my frontline staff, my nurses, my physician colleagues, our care aides, our allied health team, all the people that embraced this project, brought it to life, and really made it the success that it was. This is my incredible team that I worked with. And finally, that's my references. That's my contact information. And that is all I have.
It's amazing work, Fiona. Thank you so much for the presentation. A few of those slides, it was like mind blown of the difference that we can make, right? When we can objectively assess how sedated patients are, for sure.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.